So let us start a new topic, anti-hyperlipidemic drugs. Earlier we have seen angina pectoris, and during angina pectoris we have seen that there is a problem of demand and supply, and particularly we have seen the reasons behind this situation. Out of that, major thing is the supply is affected because of the changes in the arterial diameter, and we have seen that, and we have mentioned it many times, that it may be because of the atherosclerosis. Now, atherosclerosis, what is atherosclerosis? You have studied it in pathophysiology earlier, that it is a cascade of reaction one after another that takes place, and it may be immunological in nature or inflammatory in nature, and because of that there is a plaque formation, then the foam cells are deposited, and that leads to the decrease in the size of lumen, and this particularly causes decrease in the blood supply to the distal portions. So this is what we have studied, and it has been found, it has been known that the increase in lipid or hyperlipidemias, they are the major cause for the atherosclerosis. So whenever such kind of atherosclerosis is detected, whenever there are angina or such kind of diseases are there, we call it as a coronary insufficiency. It may be in acute myocardial infarction, it can be in angina or acute cardiac problems. So in all cases, if the major cause is the hyperlipidemic area, which is this hyperlipidemia, which is resulting into atherosclerosis, then in that conditions our main aim is to treat hyperlipidemia simultaneously. So along with the treatment of angina or myocardial infarction, we have to go for the treatment of the hyperlipidemia. Let us see what it is and how we are going to treat. So there are variety of situations. We call them hyperlipidemias, that is increase in the lipids. Particularly lipids are LDL and VLDL, they are important. Then next is hyperlipoproteinemias, that is lipoproteins are there. These are LDL, VLDL actually. Then hyperlipemia, hypercholesteremia, these are various names we call them. And along with that, there is one more condition, we call it as a hypertriglyceridemia, that is increase in the triglycerides. Okay, so lipids are increased. Lipids are always in the form of proteins joined with the proteins, so they are, we call them as a LDL means low density lipoproteins, HDL means high density lipoproteins, VLDL means very low density lipoproteins, and these are important in most of the metabolism, cholesterol synthesis, and this cholesterol is important as a base for various steroid hormones, including sex hormone and corticoid hormones, etc. So the cholesterol synthesis is essential, it is important, but at the same time what happens is if it goes beyond that, then this causes the obstructions, and it may not allow, it will form the layers. These layers will not allow nitric oxide to be secreted from the endothelium of the arteries, and that will produce so many reactions. These are all called as a atherosclerosis, and because of atherosclerosis the rigidity will be there, less relaxation will be there, the lumen size will be decreasing, and they are able to burst at any time. If they burst, then this will cause another problem, that is resulting into myocardial infarction, etc. So why what are these various lipidemias? So we know that what happens in stomach on GIT when food is taken which is having lipids into it, they are taken into that, they are converted into chylomicron, they are digested and emulsified. These chylomicrons are reaching to the capillary. From these capillaries, these enzymes are there like lipoprotein lipase, they will produce free fatty acids, and they will be metabolized. You might have studied all the metabolism of lipids in biochemistry. So these are metabolized, and they are then converted into intermediate density lipoproteins, which are converted into low density lipoprotein, and they are responsible in various tissues. These LDLs uh, are again this chylomicron, in the blood they are there. They will go to liver and they will be converted into VLDL, and again this VLDL will come back to capillaries from the liver. Okay, so these are what various activities these are producing, or this kind of lipid is there. So we have got what LDL, we have got IDL and VLDL, and one more is there HDL, that is high density lipoproteins. So these high density lipoproteins are there. These high density lipoproteins are important to maintain the balance. If the high density lipoprotein are good enough, they are sufficient enough, then they will try to prevent the problems which are caused by this LDL and VLDL. However, this LDL and VLDL will able to show the problems like atherosclerosis. So what are the treatment what we have to do? Our job is to reduce the LDL, particularly LDL-C is the important which is forming the cholesterol, and therefore that is causing the, or that is the main culprit behind atherosclerosis or atherosclerotic plaques. How we can do it? There are many ways by which we can do it. We can do it by lifestyle changes like diet, exercise, weight reduction. It can cause a modest reduction in the LDL-C, and it can cause increase in the HDL. Many patients are unable to achieve significant LDL-C reduction with lifestyle modification alone, and drug therapy should be allowed or should be given to them. And the first line treatment for that is they are called as a HMG-CoA reductase inhibitors, or they are called as a statins, and these are the primary treatment for the hypercholesterolemia. Now let us see the drugs one after another later. Then diet, exercise, as I told you, they are first one. There are other drugs also like niacin, fibric acid derivatives. They are most efficacy in the lowering triglycerides. So mind well, for triglyceride the important drug are niacin and fibric acid derivatives. Okay, and for hyperlipidemia, HMG-CoA reductase inhibitor and other classes. We shall see all these classes. Okay. Omega-3 fatty acids are also known to show beneficial effect in that. The triglyceride reduction is a secondary benefit of the statins, and the primary benefit is reduction in the LDL. So therefore statins are the primary treatment into it. So how we are controlling it? So first is diet, then we can block it, the biosynthesis by along with diet there are certain drugs like ezetimibe B. We shall see the details about it. They can be given. Then biosynthesis we can stop, that is statins we can give. That example statin means HMG-CoA reductase inhibitor is there. So this will cause blocking of biosynthesis of cholesterol. They are forming bile acids which is coming to intestine, and then it will go to the feces. So here the bile acid sequestrants are there which will stop the reabsorption of this bile acid, and they will not taken back into blood or liver, and they are excreted into feces. So these are called as a bile acid sequestrants. Then there are drugs which will improve the catabolism of lipoproteins. These are called as a fibrates. Okay. So these are various drugs, or these are various ways. This is how we can classify. We shall see classification again. So these are how various drugs are there at various stages the drugs are acting. Okay, let us see these drugs and the classes in detail. So first important class is called as a HMG-CoA reductase inhibitors, or they are also called as a statins. They are the most widely used drugs. For that there are many drugs, and they are again easy to remember that they're at the end they have same name. So example of these are, the first one was lovastatin. In that case now lovastatin is very little used because of its adverse effect. Then very rapidly or very widely used drug, still it is there in market, still it is used, is atorvastatin. Then the newer analogs are there, that is fluvastatin, then pitavastatin, pravastatin, rosuvastatin, and simvastatin. So these are variety of statins are available. These are called as HMG-CoA reductase inhibitors. Their mechanism is they causes or they offer themselves as a substrate to the HMG-CoA reductase enzyme. This enzyme is responsible for synthesis of cholesterol from the LDL and HDL, and thus it will not allow the cholesterol to be formed, and thus it will be decreasing the levels of cholesterol. The other drug is called as a niacin. Its class is niacin. Then third type of category is fibrates. That is the old drug was fenofibrate. The latest one or the newer analog of the does a gemfibrozil. Then next are bile acid sequestrants. As I told you, they will improve the excretion of bile acids. They will not allow the bile acids to be absorbed again from intestine. And these are example of these are cholesevelam, cholestipol, and cholestyramine. These are they are also called as a bile binding resins. So these are the bile binding resins which are being used. Then next is cholesterol absorption inhibitor. If in food it is coming, then ezetimibe is a drug which will not allow cholesterol to be absorbed. It will block the absorption of cholesterol. And lastly is the omega-3 fatty acids. Example of it is docosahexaenoic acid and eicosapentaenoic acids. These are available in various OTC preparations, and it is as a food supplement which decreases the oxidative stress and which allows or which decreases the formation of LDL, HDL, LDL, VLDL. So these are various drugs. We shall see these drugs one by one. So these drugs, HMG-CoA reductase inhibitors, they are competitive inhibitors of HMG-CoA reductase enzyme. It is a rate limiting step in the cholesterol synthesis. These are the most pitavastatin, rosuvastatin, and atorvastatin are the most potent LDL cholesterol lowering statins. They are followed by simvastatin, pravastatin, and lastly the lovastatin and fluvastatin. They also decrease the triglyceride levels and may increase HDL cholesterol level in the some patients, and thus it provides a triple benefit, that is increasing the HDL is also good and decreasing triglyceride is also good. So apart from decreasing the LDL, they can cause decrease in HDL, they can cause decrease in triglycerides and increase in the HDL. So this is how this is having mechanism. LDL is there, LDL is taken up by cells, and there are LDL receptors are present which allow when the LDL binds with that, it will allow its intake. Okay. Similarly, this LDL receptors are there, they will promote the LTL of from the blood. So this is how it will be there. Now next thing is that once it is coming, this acetate to HMG-CoA, they will be acetate will cause act with the HMG-CoA along with this NADP. They will convert into mevalonic acid, that is HMG-CoA to mevalonic acid, and then later it will be converted into cholesterol. This cholesterol will be taken up as a VLDL or LDL and will be excreted out. So when we block it, this cholesterol synthesis, thus it will not allow this VLDL to be formed, and thus it will decrease it. Okay. So this is first action. Then second thing is what this cholesterol is also converted into lipoproteins, and this low intracellular cholesterol stimulate the synthesis of LDL receptors, because it has decreased inside the cell, there is a decrease into that. and therefore it will act on the DNA. Because of that, this messenger RNAs will be formed with the transcription mechanism. Because of that, this ribosome will process and they will form the receptors which are for LDL. Because of this, these LDL receptors will be formed and they will able to bind the LDL. So once they are binding to LDL, then LDL will not be circulating, or it will decrease the amount of LDL which is present or circulating in the blood. Okay, so this is how the third mechanism is there. And low intracellular cholesterol will decrease the secretion of VLDL also. This is the fourth mechanism. So thus LDL and VLDL both, it will be decreasing. It will decreasing the cholesterol synthesis, and this is how the HMG-CoA reductase enzymes. So this is direct action. This is decreasing the cholesterol. Because of that, intracellular cholesterol is decreasing, and because of that, formation of low density lipoprotein is decreasing. That gives rise to formation of LDL receptor, and thus LDL will be taken in. So this is how they are decreasing this LDL and VLDL in the blood. They are most active. They are very common. They are almost used in all kind of hyperlipidemias. They are very potent in nature and very active. Almost these drugs are part of the treatment. All statins are metabolized in the liver. Some of the metabolites, you can have the table as I told you earlier, pharmacokinetic table we can make. Excretion takes place principally through bile and feces, but some urinary elimination can also occur. It causes elevation of the liver enzymes because of the statin therapy, and therefore liver functions should be evaluated prior to the treatment, and even during treatment in between it is there. Liver enzyme means, if you have seen AST, LT, or earlier they were called as SGOT, SGPT. These enzymes are giving indication or information about the liver condition. So if the enzyme level is increased, then it shows the liver damage. Sometime without liver damage it will show, but sometime doctor or the patient may be in wrong impression that it is because of the statins, and there may be actual problem in the liver, and that cannot be taken care of, and it will grow. So therefore the care has to be taken intermittently. Other liver function tests should be performed and check that whether liver is working properly or not. So what are the adverse effects? These are very common. It can affect the liver problem. It causes myopathy, and it is not used at all in pregnancy. It is contraindicated in pregnancy. So myopathy means muscle problem. It causes damages in the muscle. One more thing is there, that is called as a rhabdomyolysis, that is disintegration of skeletal muscle. It has been found with the older drugs, particularly the first generation one, but the newer drugs are having comparatively little such side effect than this one. So these are the most important adverse effect these drugs are having. Then next drug is niacin. It is a nicotinic acid. It is vitamin B component. It can reduce LDL-C by 10 to 20%, and most effective for the increasing the HDL-C level. So it causes good increase in the HDL-C level. HDL-C is a beneficial, if you remember, I told you. It also lowers triglycerides by 20 to 35%. It is in the typical doses or the normal doses of 1.5 to 3 grams per day. It can be used in the combination with niacin, and this is inhibiting the lipolysis at a gram level. So that means it will break down the lipolysis, and it is again another benefit. It is how it is administered orally. It is converted into body to the nicotinamide, and this is important cofactor, that is nicotinamide adenine dinucleotide, that is NAD plus or NADPH, you might have seen. It is its nicotinamide derivative and other metabolites, they are excreted in urine. This is the pharmacokinetics. Most common adverse effects of niacin are intense cutaneous flush. Cutaneous means skin, below skin. Flush means heat like warm sensation, and flow, and it is accompanied by uncomfortable feeling of warm. ऐसा लगता है कि कुछ गर्म लग रहा है ऐसा. And pruritus means itching, खुजली आएगी. So there will be below the skin there shall be redness, then there should be itching, and there should be what we can say flush, warmth sensation will be there. Administration of aspirin prior to taking niacin decreases the flush. That means that it is a prostaglandin mediated. Some patients also experience nausea and abdominal pain. These are the important adverse effect of niacin. Then the slow titration of the doses is required. So it cannot be given all of a sudden like that. So dose should be titrated so that it is not too much and it is not too low. So when the doses are given continuously, LDL, HDL should be monitored. This some sustained release formulation can also be used, and so initial adverse effect then it can be somehow reduced. Then niacin inhibits the tuberous secretion of uric acid, and it can causes the hyperuricemia and gout. So this is another problem it can have, that it is if there is no gout but it can bring out the gout into persons. It can cause impaired glucose tolerance and hepatotoxicity. It has also been reported, and drugs should be avoided in hepatic disease. So both even this earlier one, statins, and these both have similar problem, that as far as possible they should be avoided in the hepatic conditions. The next class of the drug is the fibrates. Fenofibrate was the first one, and then later gemfibrozil. They are the derivative of fibric acid. What they do is they lower serum triglycerides, they increases the HDL level. Then how they are doing, the peroxisome proliferated activated receptors, PPR, they are the members of the nuclear receptor family, and it regulates the lipid metabolism. So PPR function as a ligand activated transcription factors. So these PPRs are there on which certain ligands will be binding, and they will cause the activation of transcription factor. So upon binding to their ligands, natural ligand fatty acid or eicosanoids, the anti-hyperlipidemic drugs like PPRs are activated, and their fibrates are used in the treatment of hypertriglyceridemia. So by that mechanism with PPAR, okay, they will be blocking the lipid synthesis. So it leads to decrease in the triglyceride concentration to increase the expression of lipoprotein lipase. So more and more lipoprotein lipase will be there. Because of that, more lipase, more breakdown of lipoprotein will be take place, and thus it will decrease the apolipoprotein, that is CII concentration. Fenofibrate is more effective than gemfibrozil in lowering triglycerides. Fibrate also increase the level of HDL cholesterol by increasing the expression of ApoA1 and ApoA2. These are the various apolipoproteins. There are a variety of these lipoproteins are there, and they are numbered accordingly their functions. Then these both are completely absorbed from after oral absorption. Fenofibrate is a product is converted into active fenofibric acid, and therefore they are called as a fenofibric acid derivatives. Both drugs undergo extensive metabolism. They are excreted in urine as glucuronide conjugations. Then next one is bile acids binding resin or bile acid sequestrants, they are called as. So example of these are cholestyramine, cholestypyl, and cholecalciferol. These are the agents, they are acting on the bile acids. They causes the inhibition of reabsorption of bile acids or bile salts from the intestine to liver, and thus it decreases or it increases the excretion, and thus decreases the concentration of these agents. So these are ion exchange regions that will bind negatively charged bile acid, and they will bile salt in the small intestine, and once they are bind they will not able to absorb. If they are not absorbed, then they will be excreted into feces, and from that feces, because of that, their body concentration or the blood concentration will be decreasing. Okay, this is the effect. The resin bile acid complex is excreted in feces. As I told you, this causes hepatocytes to increase the conversion of cholesterol to bile acids, and because of this, more cholesterol is utilized for bile acid formation, and it is essential component of bile. The extracellular cholesterol concentration will decrease. It will activate and increase hepatic uptake of cholesterol containing LDL particles, and thus it will cause decrease in the plasma LDL-C. The increased uptake is mediated by upregulation of cell surface LDL receptor. We have seen the mechanism earlier, how this upregulation of LDL receptors are there. While we have seen HMG-CoA reductase inhibitors, we have seen that because of the less production of cholesterol, intracellular cholesterol, the receptors for LDL will be formed, and more receptor will be there. Because of that, more LDL will be able to bind with the receptors. So more surface LDL receptors will be formed, and thus because of that, the blood or plasma LDL levels will be decreased. So these are insoluble in water and have large molecular weight. After oral administration, they are neither absorbed or nor metabolically altered by the intestine. They are excreted as such in feces. See, this is very funny example. If somebody asks you, if there is a drug which is not at all absorbed in general pharmacology, suppose somebody asks you, write about, or is there any drug possible that which is not at all absorbed and not at all metabolized, and still it is a drug? Is it possible? Then yes, it is possible. If any drug is acting in GIT and it is not absorbed, it is a good thing, because it will not cause any systemic adverse effect. So it is not acting, it is not going anywhere, it will be remaining only in GIT, and it will be excreted 100% in feces. Still it shows its action, because its job is just to adsorb. It is not acting on any receptor. Okay, so this is example which you have studied of adsorption, and earlier, while in general pharmacology we have seen it. What are the adverse effects? It causes GI disturbances like constipation, nausea, flatulence, because the bile which is bound to it, that these are sort of emulsifiers, but because of the binding, they will not do, or they will not able to participate into digestive activity, and it will then cause problems somewhere in digestion, and therefore some GI effects will be there, like indigestion, constipation, flatulence, etc. Out of that, the newer one, that is cholecebulum, has lesser side effects than other bile acid resins. They can impair the absorption of fat soluble vitamins like A, D, K vitamins are there. Example, vitamin K is formed in the colon only, in large intestine, in the microbial flora. So because of that, this vitamin K will also bind to this, and it will be absorbed over that, and it will be excreted out. It will interfere with the absorption of many drugs like digoxin, warfarin, thyroid hormone, etc. Wherever all the drugs which are having similar nature, they will bind, and therefore the absorption will be affected. So other drugs should not be taken at least 1 to 2 hours. This should be taken at least 1 to 2 hours before, or 4 to 6 hours after the bile acid binding reagents. They are contraindicated in the patients which are having severe hypertriglyceridemia, which is 400 milligram per DL, because it makes it more. Okay. Then next is cholesterol absorption inhibitor, that is azacitidine is selectively inhibiting the absorption of dietary and biliary cholesterol in the small intestine. It leads to the decrease in the delivery of intestinal cholesterol to the liver, and because of that, there is a reduction of hepatic cholesterol stores and increase in the clearance of cholesterol from the blood. This azacitidine lowers LDL cholesterol by approximately 17%. So this is again a good sign, good action it is having. It is often used as an adjunct to statin or in statin intolerant patient because it is having modest LDL lowering effect. It is primarily metabolized in the small intestine and liver via glucuronide conjugation. It is excreted in bile and renal excretion. Patients with moderate to severe hepatic insufficiency should not be treated with this drug, and adverse effects are uncommon. They are not very common. In few cases only you can see. So lastly, these are the omega-3 fatty acids. These are hello. How? Yeah. So these are the omega-3 fatty acids. They are essential fatty acids. They will inhibit the VLDL and triglyceride synthesis in the liver. They are present in various fishes. Approximately 4 gram of marine derived omega-3 polyunsaturated fatty acids. These are abbreviation as PUFA, that is polyunsaturated these fatty acids. They will decrease the serum triglyceride concentration by 25 to 30% with small increase in the LDLC and HDLC. They are available as a over-the-counter prescription in fish oil capsules. It can be used for supplementation as it is difficult to consume enough omega-3 from the dietary sources. Then isopentyl is a prescription product that contains only this EPA. And it is unlike fish oil, does not significantly raise LDL. They are considered as an adjunct, they are not main treatment. So when we have to reduce the main treatment because of adverse effect or other problems, we can give this as, or it is not controlled with these drugs, then these are the additional we can be giving adjunct one. The most common side effect are omega-3 polyunsaturated fatty acids. They include the GI effects, abdominal pain, nausea, diarrhea, and fishy aftertaste. Bleeding risk can be increased in those who are concomitantly taking anticoagulants or antiplatelets. So these are various agents we have studied. This gives the table that shows that how they are making impact, and considering the situation, if the this hyperlipidemia is very high and no single drug can control, then we have to give the combination. There are many combinations are available. Example, statins are combined with ezetimibe, then it can be combined with the niacin, and as I told you, dietary supplements of polyunsaturated fatty acids. So anything such agents can be combined together in the situations where the enough single drug is not sufficient, or in other cases when we have to reduce the drug of main drug, example simvastatin or any statin particularly being used, and it is resulting into the adverse effects. We have seen muscular dystrophies and myalgias. So if this kind of adverse effects are seen and we have to reduce the dose, we cannot completely remove it, then we can give the combination so that two drugs will be there and we can lower the drugs. So these are various reasons behind the combinations. These are the drug, how much effect they can show. The chart is giving. HMG-CoA reductase inhibitors, they will cause very good profound effect on the decrease in the LDL. They can cause good increase of HDL, and they will also cause good decrease in the triglycerides. So because of this, these are the first line treatment. Other are fibrates. They are not having as much as effect, or it is a little effect on LDL, but they can improve HDL very good, and most importantly they are lowering triglycerides in a very good manner. So particularly these two drugs, fibrates and niacins, they are particularly found very useful in the hypertriglyceridemia. Then niacin is next. It can also lower LDL, but it is comparatively half of the efficacy of as niacin it is having, but it is the best for the increase in the HDL. This is causing very good increase in the HDL. The effect on triglycerides is also comparatively very good, better than HMG-CoA and slightly less than fibrates. And lastly, last two are, that is bile acid sequestrants. They are also good the next to HMG CoA reductase inhibitor in the bile acid, this in the LDL lowering effect, very little effect on LDL and triglycerides. And lastly, cholesterol absorption inhibitors are very mild in nature. They are very having very little actions in reduction in the LDL or increase in the HDL or decrease in the triglycerides. So this is a very small topic that way. Go for this, and if you have any difficulties, please let me know. By Monday, I hope you will go through. Go for the next important topics. What are these topics? If you remember, these are now arrhythmias. So please go for electrophysiology of heart. Then the next one is CCF, that is congestive cardiac failure. Go through various reasons of congestive cardiac failure. Go for heart physiology very well. Okay, and myocardial infarction. So if you go through all this, then in next week we'll able to go for cardiovascular system, remaining part of the cardiovascular system. If you have any difficulty, please put on group and try to have a discussion on group. That will help you. So far, whatsoever topic we have covered, if you wish, we can have a revision on that. But you complete it, you make the list of that, you make it topic wise, you put what topic you are reading, go through the books. I am repeating, this is almost 20-30 times I have told you. Go through the books I have told you, read the each and every line thoroughly, and then we can have the discussions. Do not shy away from reading the books. Okay, don't think that this presentation or the lecture will be sufficient enough, because anything can be asked from anywhere. So be careful and take care. Before that, I'll Saba assignment question. I want that you only draw the questions. You read the things and let me understand what you have read. Okay, I am seeing that assignment question I give, these are the big questions, and you copy it down somewhere from the book. Rather, I want to know, you give me the question, you make the questions, whatsoever you have read, and let me understand what you people are reading. Okay, so make the questions, and then that itself is an assignment. You are making question, that means you know the answer of these questions. So make the questions first. Okay, so let me see how you are doing it. Let the question comes and put it in Excel or Word format. That will be easy. Okay, so make these questions, and then we'll have I'll give these questions to you only after some time, after gap. Let me understand whether you understood it or not. Okay, your own question I'll give you after some time. Okay, so I hope you will follow this and take care. लेक्चर झालं ना बाबा, मस्त झालं.
छान होतं खूप आनंद सगळ्यात महत्त्वाचं सकाळी 9ला रात्री संध्याकाळी 7:30 ते टाईम चुकलं की बरं वाटतं. दिवसभर काही निवांत आहे ते आपलं ऐकत बसते.
नाही ते काय होतं माहिती का, असं समोर जर क्लास घेतला ना, ठीक आहे, त्या
वाटायला खूप प्रयत्न करते आणि तिथून काय काय लागतं की काही त्याला
काहीच नाही ते म्हणजे
हा म्हणजे खूप चांगलं आहे सर आपलं. फंटास्टिक. माणसं एवढं ते करतात की फक्त अपॉइंटमेंट क्लासच नाही
खर्च पोरं रिस्पॉन्ड तरी करतात.
बरं सांगू सर तुम्ही फायनली आता 50th फॅमिली सुद्धा येईल ना तुमचं. प्रदीप माने पण खूप क्लिअर येईल.
प्रदीप
काही नाही त्याची बी असेल
ते परेशान झालेत सर, ते परेशान झाले, आणि त्यांच्या परेशानीमुळे काय झाले, त्यात त्यांचा राग आणि